chronic disease. It's here to stay. More and more patients are going to have diabetes. And the next thing I just kind of wanted to show you is just about the obesity trend. So if we look at the obesity trend here in the United States, as that trend has gone up, so has diabetes. So type 2 diabetes and obesity is very much linked. And I think we have to be aware of that as nurses, that as people get bigger, that we're going to have more diabetes. And I think as nurses, we need to serve as the role model for these patients, okay? We need to be the role model. So we're going to talk about diabetes. We're going to talk about the pancreatic function. That's kind of where the beginning of this is. And you can see it's a little bit kind of flows through. When someone has diabetes, this whole process doesn't work as well. So if I've eaten and my blood sugar is a little bit high from eating, that pancreas just sends out a little bit of insulin. So insulin's released from those beta cells, and the insulin helps the glucose from the food that we eat be taken up by the cells, by the fat cells. So, and then that kind of normalizes our blood sugar again. If our blood sugar starts to fall, like in the middle of the night, sometimes when we're sleeping, our blood sugar might fall. The liver then releases glucose. So there's some, I'm sure you've already studied about, there's the liver stores up that extra glucose and turns into sugar, and it releases a little bit of glucose to, again, normalize that blood sugar. So it's this back and forth between the liver and the pancreas, all geared at keeping our blood sugar within a nice, tight window, okay? So when you have diabetes, this process is interrupted. So there are really three kinds of diabetes, and sometimes we talk about a fourth kind, which I'll talk about. But type 1 diabetes is really where your pancreas stops working. You have no insulin. Remember the pancreas, the beta cells were making insulin, releasing insulin. It stops working. So in my day, when I went to school, type 1 diabetes was called juvenile diabetes, and we thought we only saw that at Children's Hospital. People that, younger children, they were diagnosed with type 1 diabetes. The line is very blurred now. We have many adults coming here to Christ Hospital that are newly diagnosed with diabetes who we think have type 1 diabetes. 27-year-olds, 35-year-olds, 57-year-olds, okay? So we got rid of that term juvenile, and it's called type 1. Type 1 diabetic, again, has no insulin. They're not making any insulin, okay? So without insulin, they don't have that key to allow that glucose to be taken in by the cells, okay? And then type 2 diabetes, vast majority of people, 95% of the patients have type 2 diabetes. Type 2 diabetes is just really that your body has become resistant to your own insulin, and the pancreas is starting to wear out. You have a decreased amount of insulin. Now, the longer you have type 2, you might totally kind of burn your pancreas out and not have any insulin. Sometimes we say people have type 1.5, or they're kind of in between. They have some characteristics of a type 1, some characteristics of a type 2. Sometimes we look at body, the shape of somebody's body when they come in. If they're extremely thin, we're probably not going to classify them as a type 2 diabetic. Those are usually type 1s, okay? There's lots of lab work that endocrinology will do to decide what kind of diabetes the patient has. We'll do antibody antigen and some of those types of lab works. They're never back by the time they go home. Beth and I never see the end result of those. So, and then gestational diabetes is the third kind of diabetes, and that occurs in pregnant women. So when people are pregnant, women are pregnant, because you're carrying this baby, you need more insulin, okay? And sometimes that extra insulin need is not always available. And those pregnant women get diabetes. They have problems with glucose control. So they are treated during pregnancy for this blood sugar issue. These patients who have gestational diabetes are much more likely to develop type 2 diabetes in the future. So the big thing with them is making sure once they deliver, do their blood sugars go back to normal, and that they have a follow-up yearly with their physician to make sure they haven't developed type 2 diabetes. So those are the three kinds of diabetes. If you're not working on the OB floor, you're probably not going to see gestationals. In fact, they're not in the hospital all that much. We don't see a lot of them as inpatients. We do see them as outpatients mostly. Most of their education takes place on the outpatient side. So you can see type 2 is 95%, and that's kind of why I have some of this up here about insulin resistance is probably the biggest piece for that type 2 when people are resistant to insulin. So how do we diagnose diabetes? We are using here at the hospital a lot of A1Cs to diagnose. So the A1C, and we'll talk about it a little bit more, and I think you probably have the slide I'm going to talk about a little later as the next one. But the A1C is a blood test that we can do, and it gives us the average blood sugar over the last 2 to 3 months. So just like here in class, you take a couple tests, and somebody averages them out, and they come out with an average. That's what the A1C does. It's able to look at what your average blood sugar is. It gives us kind of an estimate average blood sugar over the last 2 to 3 months. So when we look at the numbers, if somebody is, 5 A1C, then they're normal. As you start to go up, pre-diabetes is 5.7 to 6.4%. Pre-diabetes means you probably have some insulin resistance, and you don't have diabetes. I think people used to call this borderline, or I have a touch. I mean, there's all kinds of different things people say. True diabetes is if your A1C is 6.5% or higher. If you fall in that category, you have diabetes, okay? So we can correlate these percentages into an estimated average. If your A1C was 7, your estimated average blood sugar over the last 2 to 3 months is 154, okay? So we can correlate these percentages over. You can also use your fasting blood sugars. So fasting blood sugar 126 or higher is going to mean you have diabetes. So that's the other thing that happens sometimes in the hospitals. People come in, their blood sugars are high, and then we'll end up getting an A1C to confirm what's going on. The hospital setting sometimes is not a fair place to look at blood sugars. It doesn't always really tell us you have diabetes or you don't. Because when people are under stress, sometimes they have what's called stress-induced or hospital-induced hyperglycemia. Sometimes just the stress of being here can make a non-diabetic's blood sugars go high, okay? Medications that we use could make people's blood sugars go high. Things like steroids, antidepressants. So some of those drugs, you don't have diabetes, but those drugs have made your blood sugars higher than what they should be. So the A1C can confirm what was going on before you came to the hospital. A lot of times patients will say things like, well, I never had this before I got here. No one's ever told me this. And kind of the A1C is like, at least if we can explain that this is what went on before you came. This isn't anything about what we're doing. I had a guy tell me yesterday his blood sugar was high because chocolate cake was on his menu and he ate the chocolate cake, and that's what made his blood sugar high. So, people can rationalize and come up with all kinds of things, but if we have that A1C, it really does help Beth and I teaching patients. Oral glucose tolerance test, not used much in the normal setting. They use it more in pregnancy. The symptoms of high blood sugar or hypoglycemia. Probably the most common ones we see is people will say they have a really dry mouth and they're very thirsty. Some of these patients that are newly diagnosed that come in, I don't know what it is about this extreme thirst, but typically people end up choosing things like gallons of juice to drink or tons of pop to try to quench their thirst, making the whole situation worse. And then people, because they're drinking more, they go to the bathroom more, okay? People tell you they're very fatigued, they're very weak, they talk about, I just sit down, fall asleep. Sometimes weight loss can be part of it, blurred vision. There are certainly lots of others, but those are probably the main ones that we see. Sometimes people will tell us they have tingling or burning in their feet, but these are typically the ones we see, especially on our newly diagnosed patients. They'll talk about being really thirsty, going to the bathroom more, feeling really tired. And especially a type 1 newly diagnosed probably will come in with some weight loss. Sometimes it can be like 20 pounds that just fell off and they don't even know why. So for a type 1 diabetic, there's only one treatment, one major treatment, and that is going to be insulin. These people don't have insulin. They have to have insulin. Insulin is life-saving. It is like oxygen to all of us, okay? It is their lifeline. Without insulin, they're going to get very sick, okay? So insulin is always part of these people's treatment. And then they also are asked to do some diet modification, some activity, kind of some lifestyle changes. Maybe if they smoke, if they're adults, not to smoke. But insulin is the big thing. And so you will see any type 1 come in. They may have an insulin pump. A lot of these patients have pumps. if we see a person that's had type 1, they've been diagnosed at the age of 5, and they come in, typically they've had pretty extensive education if they went through children's. If they're newly type 1, Beth and I might end up having to spend 6, 7 hours with those patients to give them everything that they need, depending on where they are with things. So they're always going to come in on some kind of insulin, always a long-acting insulin, a rapid-acting insulin, or an insulin pump, which we'll talk about pumps later. Type 2 diabetes is a little different. There are lots of options, and I would tell you that type 2 diabetes, we never see anybody go home on the same treatment plan. It's pretty individualized, pretty much the same with type 1. Everybody's got a very individualized plan. I think that's what makes diabetes very hard. Most other medications have like a range or a limit or a recommended dose. There is no real, I can't tell you that the insulin, there's a recommended dose. The dose is whatever works for you. We could see somebody on as little as 5 units and somebody is on as much as 500 in one day. So that's kind of what makes diabetes a little bit unique. It's very complex, and we have to really, everything is very, very individualized for that patient. So for type 2, I talk about the foundation of their care. To me, if you're building a building, you want to have a good foundation, and a good foundation for diabetes management for any patient is going to be the lifestyle changes that they need to make. And they're big. Diet, physical activity, weight management. They're things that people always, make for those New Year's resolutions and have a hard time keeping. These people have to keep that resolution the rest of their life. So I tell people I hate the word diet. It's healthy eating. It's not putting somebody on a diet. It's really eating healthy, that they're eating what all of us should be eating, basically. So we talk a lot about diet, and we talk a lot about carbohydrates and things like that. So it can get pretty technical for people. Activity, the more active they are, the less resistant they are to insulin. So physical activity is very important for these patients, and it's usually recommended 5 days a week, 30 minutes each of those days. So again, we're talking about like another commitment they have to do. And then weight management. The bigger people are, the more resistant they are to insulin. Lots of recommendations out. In fact, I just heard it on TV last week that studies are showing as little as a 7% improved loss of body weight can improve diabetes. So that for some people can be a big challenge to lose 7% of their body weight. How many people in here have tried to lose weight, and it's a battle just to get 5 pounds off or 10 pounds off. I typically tell my patients to just set a very small goal, celebrate when they reach it, and then set another goal. So with diabetes, oral agents, I could not list all these, as Beth said. Since I did this slide, there are, 5 or 6 new drugs out. Now inhalable insulin's just coming out. So there's lots of drugs, lots of oral medications. And we do not in the hospital use these oral medicines. While they are acceptable on the outpatient side when people are home, in the hospital there's been no evidence that they are safe to use in the hospital. A lot of them are filtered more through the kidneys, the liver, and when you put people in the hospital, many times kidneys get compromised. So we don't use these drugs. They're a little bit action and not really predictable. The places that we use orals, there's 2 places that we would use any of these oral medicines. One would be on behavioral health, because those people are not here for medical issues. They're here more for psychiatric. And then we'll use them on our rehab unit. And occasionally if we have that pregnant diabetic woman in, we might use some orals on her. But for all of our medical floors, we want to handle diabetes with insulin. And so then there's also all of these non-insulin injectables, Byetta, Victoza, Bydureon. You've probably heard about those on the news. And then insulin. So these people might be on nothing and just controlling it with lifestyle. They might be on lifestyle and an oral medication. They might be on lifestyle and up to 3 orals, lifestyle, oral, and 1 insulin. It's the whole gamut. It can be about anything. Okay. So type 2, I just want to go over again because this is going to be 95% of your patients. It's a decreased insulin production in the beta cell. Not enough insulin is being made, okay? And those beta cells can actually burn out. And we see people that happens to. They've had type 2 diabetes for 20 years, and especially people that have not taken good care of their diabetes. They're challenging that pancreas all the time with pop and candy and cakes and cookies, and that pancreas can't keep up with the demand. And they kind of burn their pancreas out is what we say. and they also are very resistant to insulin.